Hello everyone, my name is Sandy and I'm going to be doing my student presentation on groin rash. So this case study begins with a fictional man which I've named Keith. He's 45-year-old and he presents to the walk-in clinic where his chief concern is of a groin rash. It is reported that Loxazone cream and nystatin creams have both failed. So before I walk in the room, I'm starting to formulate some differential diagnoses. The first one would be that this is some sort of infection of the groin, and because he had previously been prescribed Loxazone cream and nystatin, I'm assuming this is some sort of fungal infection. And if it's in the groin, I'm thinking jock itch, or the medical term for jock itch is Tinea Cruris. So before I walk in, I'm kind of thinking of the couple of things here. Did he have a treatment failure because he was non-compliant with how he was applying the cream? Or is there a treatment failure because he was on the wrong drugs? The other thing I'm thinking of, was there an initial error in the diagnosis? Does he have some sort of other skin infection? And of course, the last thing I'm thinking of, but it's still in the back of my mind, with a rash that has failed treatment, is there some sort of immunosuppression going on? And of course, the immunosuppression will be the zebra in the room at this point. So I walk in and I meet Keith, and he tells me that over the past couple of months, he's had this itchy red rash, describes it between his legs, it's not going away, and it is driving him crazy. And because he's in the walk-in clinic over the weekend, he did not go back to his doctor. He wanted to come here to get something figured out because nothing that he's tried is working. He reports to me that the rash started about 2 to 3 months ago, and it coincided with a new job. He's a long-distance trucker, so he's seated in his cab for a long period of time. Interestingly enough, he does take showers at truck stops, and this is important for later in the story. He tells me he's tried Loxazone cream, nystatin powder, and he says he has been compliant with both treatments, applying it as the doctor told him. And incidentally, he reports that his feet are itching as well. A quick review of systems: he denies any current or past medical history. He denies having ever had any surgery. He denies taking any over-the-counter medications or prescribed medications. His family history for this is non-contributory. He denies that anybody else in his family has a rash, or itchy feet for that matter, and he has no known allergies. Upon physical assessment, I take a look at the rash, and it is located on both of the inner aspects of his thigh in the groin area. And as you can see, it's very red. It's very well demarcated, and there are some small vesicles noted. His vitals are stable. He is an obese male. He has a BMI of 32. As I continue my skin assessment, I look at all areas of his skin, and the only thing that I see positive are some red scaly feet. Incidentally, I have palpated the lymph nodes while assessing the skin, and I have not appreciated any palpable lymph nodes. So at this point, my suspicion is really high for some sort of fungal infection. However, not all fungal infections are alike. Namely, the two big ones we see are Candida and fungal infection called dermatophyte. So one of the tests we can do in the office, if the office does have this capability, is what is called a KOH test. So the KOH stands for potassium hydroxide preparation. What you do is you take scrapings from the edge of the fungal infection and you put it under a slide after it's been prepared. And if it is a fungal infection, you will see what is pictured on the right. It's typical for a fungal infection where you see the long strands, and those are called hyali. Another test you can do in the office, it's a Woods lamp. This is a UV light that is shined over the rash, and it's done in a dark room. Usually fungal infections do not fluoresce. However, this test can rule out another type of infection, which is a bacterial infection called Erythrasma. In this case, Keith's groin rash and feet did not fluoresce. So I can rule out a bacterial infection at this point. Another thing you can do is do a fungal culture. However, fungal cultures take many, many weeks to come back. So this is typically reserved for a rash that really does not want to go away, just to make sure that it is a fungal infection, what type of fungal infection, as well as to rule out any bacterial infection that may have been missed. So after my assessment, after looking at the skin, after reviewing the tests I've done, after reviewing his history, I am pretty sure he has a dermatophyte infection of the groin, or Tinea Cruris, and also a dermatophyte infection of the feet, Tinea pedis. I'm thinking that the previous treatments have failed because of an undiagnosed Tinea pedis, and because of this, he has reinfected his groin while putting on his pants or his underwear. So the thing with these infections is that you can contaminate other parts of your body. So I am pretty sure that because the feet weren't treated, perhaps the Lambicil, the lotosome was working, but he kept on reinfecting his groin. Also, lotosome, because it has the addition of betamethasone, it could have aggravated the infection because topical steroids can cause increased redness, increased itching, and that may be a little bit of what's happening as well. And again, the nystatin failed because this is not a candida infection, it's a dermatophyte infection. So treatment with nystatin basically did nothing for this patient. So before we can talk about treatment and why I'm choosing the type of treatment I've decided to choose, a little bit about a dermatophyte infection. So basically a dermatophyte is a class of fungi and it needs keratin to grow. And this is located on the very top layer of our skin, or our dead skin, called the stratum corneum. Also, tinea is Latin for ringworm, and it gets this name from the ring-like appearance that is sometimes seen when the infection is on the body. Also, tinea infections are named for the location on the body. So for the feet, which is pedis, it would be Tinea pedis. For the groin, that term is called Cruris, so jock itch would be Tinea Cruris, and if it's on the scalp, it would be Tinea capitis. Dermatophytes thrive in the warm, moist areas, so the groin and the feet are very warm and moist. It's important to know that dermatophytes are eukaryotic cells. This is important because our treatment will target the cell membrane of this fungal cell. The treatments are directed at destroying that cell wall, and again, Candida is a yeast, but treatment differs in dermatophyte infections. So to treat a dermatophyte infection, there's two main classes of drugs that we can use. They're called azoles or allylamines. Azoles are drugs like Lotimin or Lotozone, where Lotozone is basically Lotimin with the steroid added to it. And the generic term for Lotimin is clotrimazole. This type of drug is known as a fungistatic, just like we have bactericidals and bacteriostatic drugs for bacterial infections. We have the same thing for fungal infections. Allylamines, one of the well-known allylamines is Lamisil or terbinafine, and that is known to be a fungicidal. So which one to use? Well, he's tried the Lotimin, he's tried the azole, so my thought is maybe try an allylamine drug. So I did a lot of research and I did find that in a lot of studies, the allylamines versus the azoles show that allylamines are very superior to the azoles. So to me, this would be well worth a try to try another cream or an ililamine type cream, which would be Lamisil. So there are different treatment options. It is a refractory fungal infection. So there are topical choices and there are oral systemic choices. So the first choice I would think about is the Lamisil cream. It's attractive because of the studies I've read where ililamines are superior to azoles, and also it is fungicidal versus the azole, which is more fungistatic. Lamisil also has a very broad coverage, and it's good for resistant infections, especially when azoles have failed. Attractive thing about Lamisil, it's applied once a day for just 7 days. And again, the studies have shown that Lamisil or the ililamines are more effective than the azoles, and the cost difference is not much. The other option would be to attack this rash systemically. And one of the systemic azoles that is used is diflucan or fluconazole. Now, fluconazole can be given just once a week for 2 to 4 weeks, or in smaller doses once a day for 2 to 4 weeks. This is usually reserved for extremely refractory rashes, and at this point I'm not 100% convinced that Keith has failed all topical treatment options. In order to demonstrate how these antifungals work, I've created this simplified version of where these different antifungals work on the process of the fungal cell synthesis of a sterol called ergosterol. To simplify it even more, ergosterol is kind of synonymous to arosterol on our cell membrane, but our sterol is called cholesterol. So our cell membrane is made of cholesterol and proteins, and as such, the fungal cell is also made of a sterol and proteins, but the fungal cell sterol is called ergosterol. So these agents are targeted at destroying the process by which the cell makes their ergosterol, which is a good thing because it leaves our cells alone. So the two classifications of drugs that target ergosterol are the azoles and the ililamines. And how the ililamines block the final ergosterol is by where I have it in red, where the ililamines block the synthesis of the enzyme squalene epoxidase. And by blocking this enzyme, then squalene cannot become lanestrol, that cannot become ergosterol. In similar fashion, but at a different part of the cycle, the azoles block the enzyme cytochrome P450, and as you can see by my diagram, by blocking the enzyme cytochrome P450, the fungal cell cannot then go on to make ergosterol and eventually dies. The problem with the oral azoles are that because they decrease the cytochrome P450 in the fungal cell, unfortunately they decrease it in the human cell as well. So you have to use it in caution with a patient who is on any other drug that also is used or also uses cytochrome P450 to metabolize it, because by downregulating this enzyme, you are increasing the dose of the drug intrinsically, which could lead to toxic effects. Lamisil, because it is a topical application, is fairly safe. Less than 5% of the drug is absorbed systemically after it is applied. And the good thing about Lamisil or terbinafine is that it remains active on the skin days after the last application. It's a very lipophilic product, so after the last application, it continues its fungicidal property long afterwards. So it makes it an attractive drug to use. On the other hand, anything that is systemic carries a little bit more risk. Oral fluconazole is one of the drugs that has a very long half-life, averages about 30 hours, with anywhere between 20 and 50-hour half-life. You need to use it in caution with anyone with a renal impairment because it is excreted by the kidneys. Also use in caution with anyone with any type of liver impairment or liver dysfunction, as it is metabolized in the liver. There is a rare incidence of the prolongation of the QT interval, and this phenomena is marked with people who are taking drugs that also increase the QT interval. Some examples would be antipsychotic drug called Haldol, or some of the class 1 antiarrhythmics like procainamide or flecainide, or class C antiarrhythmics like amiodarone. And of course, I've discussed before that it does inhibit the cytochrome P450, so with those patients who are taking drugs who are metabolized by this enzyme, then that drug will be increased, and so the patient will be more likely to get toxic of other drugs in concomitant uses with fluconazole. So based on everything, risk, benefits, patient preference, likely cause of ongoing rash, I've decided at this point to prescribe Lamisil 1% cream. It's attractive because of its fungicidal properties. Also, I'm not convinced that he has a refractory rash at this point. There's a high suspicion that the untreated and undiagnosed athlete's foot, or Tinea Cruris, was reinfecting his groin while he was putting on his shorts or his pants. I'm thinking if you treat the Tinea Cruris and treat the Tinea Cruris with Lamisil, the likelihood of his infection to clear will be high. Of course, the goal is going to be to eradicate both infectious areas of the feet and groin. If by chance that the topical treatment fails and he has done everything I've told him to do, then I may consider treating him with an oral azole, like diflucan. And there's also going to be the option of, if he even fails diflucan, then maybe explore the zebra, which is immunosuppression. After discussing his treatment options, the patient has decided that he's in agreement to using the topical cream because for him it makes sense that he was reinfecting his groin with an untreated athlete's foot infection. Now that Keith and I have decided to treat his groin rash and his athlete's foot with Lamisil, I have educated him that he needs to apply the cream to both areas once a day for 7 days after he's taken a shower and completely dried off. I've also educated Keith that there are no systemic side effects to the Lamisil, and he may have a transient burning when he first applies it. However, this should go away with treatment. Also, he's not to stop the treatment even though the rash seems to be improving. And again, instructing him he needs to keep the areas clean and dry, especially after the infection has cleared, to continue keeping areas clean and dry. Also important is to use a different towel to wiping his feet and his groin so he does avoid any cross-contamination and then having to come back in the office because now he's got a fungal infection on his arm or on his core body. He also is instructed to wear loose-fitting clothing because he sits in the truck for long periods of time. Sitting, it can get very hot and sweaty, so it will be important to wear loose-fitting clothing and also loose-fitting shoes and cotton socks. Also important to educate Keith about is when he does take public showers to use his own footwear as like flip-flops or any type of other footwear that he can shower in. And of course, he is to return to the clinic or to his primary care doctor should he do all this and the treatment fails. So I want to thank you for listening to my presentation, and a couple things that I've learned doing this presentation and that I will carry to me within my practice is when a man presents with a groin rash, it's very important to do a total skin assessment, especially of the feet, to make sure that there is no cross-contamination going on. And also prior to this presentation, I did not know that all antifungal creams were not created equal. So now it's good to know that there are options of the azoles or the lotimens or the allylamines or the lamicells. Thank you.